morning, everybody. So thank you very much for inviting me to talk. My name is Ari Parnham, and I'm a consultant at the Christie's NHS Foundation Trust in Manchester, and also at Wirral University Teaching Hospitals as well. And I've been tasked to talk to you today about updates in penile cancer. And penile cancer is a rare disease, but actually has quite a lot of research, both in terms of basic science, translational, and clinical. And to be able to cover the vast range of what's been done on that would be quite difficult. So I've actually just chosen some areas that I think are quite interesting. And so I'd like to cover a little bit about human papillomavirus and vaccination, because that's coming up. Managing the primary and managing the lymph nodes, and also systemic treatments and collaboration. So for those of us who manage penile cancer probably know this, but those who don't, most penile cancers are driven by two reasons, with inflammatory cause and also virus-driven, so that's HPV predominantly. And HPV is a double-stranded DNA virus. It enters in through the skin, so it's epitheliotrophic. And it exerts its carcinogenic effects via E6 and E7 pro-oncogenes, which affects P16 and P53, leading to reduced apoptosis and increased cellular proliferation. And this mechanism is fairly well recognised in the sense of across many cancers, and probably most of recognised would be cervical cancer. And as a consequence of that, HPV vaccination for girls was brought in 2008. Girls from the age of 11 to 12 have a vaccine. They have it's a two-dose schedule, and they get a quadrivalent vaccine. That's 6, 11, 16, and 18 HPV subtypes, which are covered with that. And that's been going really well. So the penetrance of that in the population is around about 85%, which, looking at other programs like Australia, is pretty good, actually. But the question is, has it made any difference whatsoever? Well, it's a bit too early, really, to make any decisions on that from a cervical cancer point of view, because it's only 10 years and it's been going. But there has been a systematic review, this is a Cochrane review, actually, looking at HPV vaccination in girls and whether it's made a difference. And they were able to look at pre-cancerous changes, that's CIN2 or 3. And actually, they found that they reduced it by 46%. So it's making some inroads there, and I think it's obviously a good thing on that basis. But how about boys? Well, in September 2019, men or boys will be getting HPV vaccination as well, which is good news. And that was brought out in the statement document in July 2018 from the JCVI. And that means we will join this list of countries as the only countries that offer male vaccination. And I say offer, if you look, for instance, the US, it's a voluntary program pretty much. It's not inbuilt into schools, unlike ours. Australia's a little bit more like ours as well. And so why do they do this? Well, this is basically what they've said in their statement. So hopefully will augment the existing immunisation programme. And obviously, if you're immunising boys, obviously most of them won't declare themselves as MSM, which is what we now currently vaccinate. So hopefully it'll build up upon that. And certainly some data from that previous Cochrane review would suggest that if you vaccinate people prior to their exposure, they have better outcomes as well. Hopefully it'll provide long-term resilience to the programme. It will reduce the HPV burden sooner with a girl-only program. And one of the things that previously stopped this coming through was a cost analysis based on the fact that head and neck cancers, about 30% of those were down to HPV virus. But actually that some data which we'll come on to in a minute or two, would suggest it's around about 60%, and that obviously changes the cost analysis. And obviously equality as well, so equal healthcare access to all. So looking a little bit about oropharyngeal cancers, they're quite similar to penile cancers. It's actually quite common in around about 8.9 per 100,000 people. And if you consider cervical cancer as around about 9.3, they're pretty similar. It has 1 in 2 of them are down to HPV or HPV driven. And the ratio, most of these are men, so it's 3/4 of these people are men. And its incidence is going crazy. If you look at it, it's 101% increase between 2002 and 2011. So you can see how this has driven the agenda for gender-neutral vaccination. And if we look at penile cancer is very similar in the sense, yes, the smaller numbers, incidence much less, but again, 1 in 2. It's increasing about 23% since 1990. And again, it's similar kind of profile in the sense of HPV. If you can see the pie chart around the picture there, and the green is HPV 16, which is the most common, then 18 on the orange, and 6 and 11 on the grey bits. So obviously, hopefully, this will make a difference in terms of penile cancer survival and incidence over time as it comes in. Moving on to managing the primary, if I'm going to be honest with you, not much has really changed in managing the primary. There's been work, obviously the paradigm has changed over the number of years, especially since centralisation. Work by Hoffman, Agwal and Minas obviously said that we can take less margins, and so we're looking at more penile preserving surgery. And there's been some more reviews about that and multi-centre studies that have kind of reinforced that. And it's understandable why we're moving in this direction. If you look at this paper here, this is this was a systematic review, and it basically says that 40% of men with penile cancer had impaired well-being, 31% had pathological anxiety, and 53% had some degree of mental illness. Is there any other disease that we can think of whereby this you do with a partial penectomy or something like that, whereby you wouldn't reconstruct them? Well, no, there isn't. And if we look at kind of breast cancer is a really good example of this. So back in the 1960s, if you had breast cancer, you had a mastectomy, and that was pretty much all your lot. But then when you had the kind of women's revolution and things like this, which was mainly driven in the US in the 1970s, 1980s, this is what then came out of it, and this is a reconstruction, which I think is really good. I saw this picture on the internet, and this is a DEPT, which is fantastic reconstruction work. And so should we be offering the same to penile cancer patients? And the answer is yes, we are doing it, but this is kind of some of the things that we see in our units. This is someone, most of us who do penile cancer will recognise this. This is a gentleman who's had a penile cancer. You've had to take what you've had to take. You didn't want to do a total penectomy because realistically that's not very nice either, and so you've left him with some sort of protuberance. But obviously on the right-hand side, this is what could be offered, and this is phalloplasty, which for those who recognise it, and that's obviously going to hopefully make some significant differences to patients' outcomes. This was a study that was presented, a poster presentation at AUA, which I thought was quite interesting, actually. This is from the UCLH group. And if this is looking at radial artery forearm phalloplasties, followed by gland sculpting and penile prosthesis implantation. And if the interesting bit about that, again, that pie chart around that 108 patients that were studied, actually about a quarter of these, the orange bit, were penile cancer patients. So clearly there's a need for this operation in those people. And their outcomes were pretty good. So if you look at it, their satisfaction rate was 80%, 76% would say they would have it again, and a lot of them also had penile sensation. Managing the lymph nodes. So managing lymph nodes is always very contentious. There's a lot to talk about it, but one of the things I wanted to focus down on was this survey that was submitted to all people who did penile cancer through eUrogen. eUrogen's an EU-driven initiative, basically trying to centralise rare cancers, or at least provide centralised advice. And they sent out 94 questions to its members, and also worldwide, and got 55 responses, which I think is pretty good for penile cancer, bear in mind being a rare disease. And there's loads of questions. You could spend all day going through the questions that were put through, 94 of them. But some of the ones I picked out, which I thought was quite interesting, is this was, do you perform dynamic sentinel node biopsy regularly in your patient cohort? 70% of people said yes, but that 70% is pretty much exclusively European, and the rest of it is American and outside of Europe. And the question in my mind is, well, why are people not taking on DSMB outside of Europe? Is it because of, well, what is it? I guess the answer was probably something along the lines of, well, you need to have high numbers, and most people aren't centralised, so that makes it a little bit difficult. And the other thing is the infrastructure that goes along with it. You have to have a nuclear medicine department, and that costs a lot of money. So, which leads us on to this. This is a UK-based trial. This is the Centipen trial, which was an NCRI badged one. And this is basically doing DSMB in a slightly different way. This is using iron nanoparticles that are injected in exactly the same way. You don't have the lymphocytogram, but you use a magnetic probe, which then allows you to localize the lymph node. And that has some benefits for it. You can obviously see, especially not necessarily in our environment, but in kind of less fortunate environments. It avoids radiation. It's surgeon controlled. You don't have to inject it. With dynamic sentinel node biopsy, you have to inject it 24 hours maximum before you do your operation. This you can do up to 7 days. So you can bring them to an outpatient appointment, and then they come back later. Inexpensive, and this was a vaguish cost analysis that we did very quickly yesterday, looking at, so in our department it's about 5330, this is for someone who wasn't very well in the general point of view, and then compared to 4500. So there is some degree of saving there that may be had with it. And so the study looked at 10 patients, 17 groins in total, they both had an injection for the radio-labeled nanocolloid and also the Centimag, and the results show that basically they've identified 34 groins in the mag trace, lymph nodes in the dynamic sentinel node biopsy. The key thing here, though, is that both the 3 nodes that were positive were identified by both studies, and therefore the concordance, or Cohen's kappa here, was quite high at 0.941, which says it shows good correlation. Other things from this survey that was picked out was the how people are managing their inguinal nodes, so from a sense of radical groin node dissection. Most people are doing open groin node dissection. There are a few people around the country doing laparoscopic and robotic, and that includes Europe. And then the second graph on the bottom here, I think is really interesting, is this was asking directly, what do you do in real terms for a radical groin node dissection? Bear in mind, a radical groin node dissection, if you were to be true to it, doesn't involve preserving the long saphenous, does not involve preserving the fascia lata, but does involve dissecting the vessels. So what we're seeing here in this predominantly European cohort is actually most people seem to be preserving the long saphenous, most people are preserving the fascia, and most people are dissecting the vessels or around the vessels, which is not truly a radical groin node dissection. And that has implications, clearly, for studies that go on for that. This is just looking at lap groin node dissections. I just wanted to make a comment on this. So there's some centres that are now taking on lap groin dissections. It seems to be gaining some traction. So there's Norfolk and Norwich, there's Christie's, and there's 2 centres in the south also. In London are about to start their lap groin node dissection programmes as well. And whether it's the way to go, I don't know, but time will tell, I guess. The other thing is also post-op care and how we manage them seem to be very disparate in this survey. So, for instance, post-op antibiotics, in times of antibiotic guardianship, it ranged from 1 day, that sounds okay, to until the drain came out. When would you do that in any other circumstance? And so drains were staying from 3 days until the drain was dry. Drain dry could be like 40, 50 days of antibiotics. So that's a good question that needs to be answered. And also, this is another one is no one really is quite sure it would make from this is, do you give them VTE prophylaxis? 54% did, as an extended VTE. This is kind of pelvic surgery. It's not true pelvic surgery, but still pelvic, and it's still a cancer. So should we be doing that? And that's a question that needs to be answered as well. Just a very quick mention about impact study. This is the International Penile Advanced Cancer Trial. It's a great trial. We should try and support this trial, I think. Its recruitment started in March 2017 with an aim of about 400. It's based in the UK, North America, and Canada. In the UK, 2 sites, US 9 sites are open, and it's recruiting, but slowly, I guess, but hopefully it'll pick up pace as some centres are coming online in the next couple of months from the UK. 14 patients in the US and 5 patients in the UK, so 19 in total. And this is the protocol. I won't go through it. It's complicated, but it's there. Systemic treatments. One thing we do know from penile cancer is if you have lymph node involvement, if you have N3 disease, your chances of survival are pretty abysmal. You're looking at around about 33% survival. If you look over time, that hasn't really changed. So this is a study here looking at JOSHI. This is a US-based study looking at between 2004 and 2014, looked through their national database, N+ disease, 1,123 patients. And they said, okay, if we're going to do operations and give them chemotherapy or radiotherapy, which of these is making a difference? Is anything making a difference? Well, actually, this is looking here. The only thing that did make difference was the lymph node dissection. There you go. If you had a lymph node dissection, your hazard ratio is 0.64, statistically significant. But actually, if you look at these ones, these survival graphs here, this is looking at lymph node dissection, didn't have a lymph node dissection, but had chemotherapy, radiotherapy in the top one. And the bottom one here is chemotherapy and radiotherapy with a lymph node dissection. No statistical difference, which suggests to me that actually lymph node dissection is the only thing here that's making any sort of survival, and the chemo is really doing, and the radiotherapy is doing very little. So what else is there out there at the moment? What's the future? I guess this is the thing that everyone's talking about in every part of urology or oncology, and that's immunotherapies. And we know that if you've got a penile cancer, about 30 to 65% of them experience PD-L1. And this little study here, this is with UDEGA, they looked at a reasonable cohort. They actually had matched samples of penile cancer primary and inguinal lymph nodes, and they compared them. They had 10 that were matched, so it's not big numbers. But of those 10, they correlated pretty well. So, for instance, if you had PD-L1 in your primary, you would also have a lymph node that was positive with PD-L1 as well. And you can see there's the histopathology on the side that you can see on the top one, that's PD-L positive. They correlate the top one being the primary and the bottom one being the metastasis. And on the bottom one, that's being negative and negative. I guess the next step after this, and I don't know if that's the answer realistically, but one of the things that seems to be coming along as well, if we look in other specialities, is combining this with immunization or some sort of sensitizing agent. So, in other words, giving maybe a vaccine, which we've already talked about, and adding in some sort of immunotherapy before. And this is a study. This is not penile cancer. This is looking at all squamous cell carcinomas, and this is a waterfall plot, and this is looking at response. And as you can see, actually, there's a good number of people on this right-hand side which seem to be having good response with that combination therapy. The other thing I think is quite interesting, well, which I think is good for the UK, is this. This is HARE 40. This is a Southampton-run study looking at well, actually not just penile cancer, looking at all squamous cell carcinomas, but in 1B arm squamous cell carcinomas. And they're doing exactly this, using some sort of immunotherapy and adding in a sensitizing agent or some an immunization on top of it. And that will report in the future, I guess. But I think we should try and recruit to that as it's UK-based. The other thing is basket trials, which I wanted to mention a little bit about. I think this is probably the future in rare diseases. So this is whereby you have a patient who has a cancer. In our circumstance, when we do this at Christie's, it's often someone who's got advanced cancer, has tried first-line chemotherapy, so target trials after first line. The biopsy and the blood sample undergoes next-generation sequencing. They identify any actionable mutations, and then they look through all the kind of the options for trials that these patients could be added onto in phase 1, and then given them. And I think that's probably one of the ways that we should be looking at kind of making personalised medicine for penile cancer. Collaboration, I think collaboration is really important. I've mentioned the Eurogem for people who've heard me talk before, and it's one of, I think it's a really good project. This is a European-sponsored project. It has money behind it, which I think is good. And really, in rare cancers, we need to look at these kind of models. It's based on centres that have been identified, and you can apply to be a centre if you want to, if you're interested in penile cancer and have a centre that does good work from that side of things. And here you can see the kind of spread of centres that are currently recruited. I'd encourage for those people who do penile cancer really to kind of try and sign up to that. I think it will be of benefit to everyone. And that's it. Any questions?
Thanks, Harry. That was very good. If you have any questions, please raise your hand and we'll try and get to you. And as I said, use the BAUS app as well. But first of all, could I just ask, Harry, you talked about laparoscopic lymph node dissection. Is there any data on improvements in terms of shorter recovery time?
Yeah, so actually there's been a study that was done in Norfolk and Norwich. That was what most of it's been based on for penile cancer. That was looking at Valand, and that was a comparator study. It wasn't randomised, but it seems to suggest that length of stay was shorter. But the main things was the complications, actually. So if you looked at the lymphedema rates were reduced, so it's around about 30% if you look in the literature for open groin node dissection. It reduced to around about 5% with the laparoscopic groin node dissections, less wound, no wound dehiscence or very little wound dehiscence as well. So I think from a complication point of view makes a difference. Oncologically, it also appeared safe, so the lymph node count was slightly higher in that data as well than the standard open groin node dissection, but you could put that down to how they were analysed. So you'd say it was equivalent, but small numbers at the moment. And I guess that's calling out for things in the future to look at and examine. That's why I think it's good that other centres try and come on board with it.
Okay, I mean, that was an excellent talk, and maybe it's unfair to ask you this, but do you think the time has come in this era of gender affirmation surgery that we have another centre in the UK doing free flat phalloplasty?
Yeah, I guess it's a good question. I mean, as I say, from this side of things, I think we're doing men a disservice in that side of things from a penile cancer point of view, being a rare disease, bear in mind. But I think, we've got one centre they supply the whole of the UK, and there's a few centres that are doing it, so I guess it would make sense to a degree to have another centre, but, I mean, how you do that, I don't know.
Ari, there's one question that's come in, which I'll read it out verbatim. You have mentioned iron particles, but have you used ICG labeled technetium-99 with intra-op fluorescence for your sentinel node dissections?
Straightforwardly, no.
Okay.
But, I mean, it's something that's out there, and certainly that's some centres are doing that. I think it's not a bad idea. I'm not sure what it adds additionally to what we already do in the sense of dynamic sentinel node biopsy. I think it makes it easier to find your sentinel node, certainly. From the kind of the data that's out there and looking at the images, it looks simpler to find it, but we don't do it ourselves, no.
And in view of the sort of lag time for the vaccine to work for boys, do you think you'll see a reduction in penile cancer incidence in your career?
No. I suspect not.
I think this is going to be the final question. It's Mike Fraser, I think, out there.
Ari, thanks very much for your talk.
That's all right.
Thing that bothers me is we are spending a lot of money on technology and trials and laparoscopic surgery and phalloplasty. At the front end of all this is a major cry out for education. One of my trainees presented a paper at the ISSM this year about people still presenting with very advanced penile cancer. I equate this to when I was a resident, I used to see women being admitted to hospital with T4 breast cancer, and we see T4 penile cancer, and we're 2 generations behind what I want to know is how do we educate the guys out there and the GPs to look at this?
I think it's a really good question. The answer is I don't know, realistically. People have tried different things. So there was a Man in a Van, I think, programme that was sponsored. I can't remember, got a grant. Went around the whole of Wales, informing people and the rest of it. Made a very short-term difference. I guess the thing is making something that's robust and long-term awareness. Because in the clamour that you get from other cancers, like, say, for instance, prostate, which is understandable, higher incidence and the rest of it, penile cancer is a small area, isn't it? And trying to get that your message across has to be a long-term strategy. I don't have the answer to how you do it. I guess it's just it's awareness-raising events that you do in your locality and make it open up to GPs. And certainly we see the same as you, I think, Mike, is that most of our patients that are coming, especially in the north of England, where kind of there's a degree of poverty and poor access to services, we get quite advanced disease. And you kind of think, well, why aren't we getting these earlier? And I think that's something that really, as a strategy, maybe we should look at as a group, and the UK is well placed for that, and centralisation. Maybe, again, collaboration and getting together and thinking of ways we can do that. Probably is the only way we can go.
No time for more questions, I do apologise. Can I ask Professor Nick Watkin to come to the stage now? That was an excellent talk, thank you, Ari. Nick Watkin, known to all of us, published widely on Peyronie's, urethroplasty and penile cancer. And he's taken over from Professor Rob Pickard, who sadly passed away, and he'll give us an update now on the open trial.
Paul, Trevor, ladies and gentlemen, thank you very much indeed. And of course, we all know that Rob was the chief investigator of this trial right from the beginning, and I took over when he was unable to continue in that role towards the end of the study and the analysis. So I'm going to tell you the final results of the open trial. That's obviously open urethroplasty versus endoscopic urethrotomy, a randomized trial which recruited across the UK. I'm sure a lot of people in this audience will have been involved in the initial recruitment. And we mustn't forget that this was a trial which was also conducted essentially through Newcastle University and University of Aberdeen trials units. Now, this is the first time I've tried this technology, and those of you who have mobile phones with you and can get onto the BAUS app will be able to access the Andrology section, and you should be able to vote on a single question, which I'm going to pose to you in just a moment, so I'll give you a few moments to sort that out. But whilst we're doing that, just want to remind you about the relative differences between the surgical procedures, and this is just HEST data from 2016, 2017, but it's very similar whichever year you take it. There's about 750 urethroplasties performed in the UK, and about 5,000 urethrotomies and a similar number of urethral dilatations. And we mustn't forget that really this trial is about penobulbar strictures, so the numbers will be slightly different, but essentially the difference between the two is quite stark. And we know from historical data, and I've just picked out two examples here, that we would probably be expecting about a 50% recurrence rate if you've had a urethrotomy or a dilatation, and perhaps about a 20% recurrence rate if you've had a urethroplasty. Very broad terms, very general data, but that's probably what people are telling their patients. So here's the question. Would you advise a urethroplasty to a young man with a single recurrence of a bulbar stricture, which is symptomatic? He's turned up to your clinic with this story. I don't quite know how that, if I press, oh, okay, there you go, vote now. Okay. Do we get that data first? Oh, it's either side of us, I can't see that. Okay, so about 3/4 of people would offer a urethroplasty. I can see the sides. Okay, that's very interesting. We'll repeat that question at the end of the talk. Okay, so the trial that we designed many years ago was actually allowed to happen in many ways following this paper that a group of us collaborating quite a few years ago. And it was essentially designing a tool that allowed symptomatic measurement of differences in outcome, as opposed to the objective measures that we all use, flow rates and so on. So we devised or defined a urethroplasty symptom score, a validated patient-reported outcome questionnaire, which really was the cornerstone of the trial that followed on from this. And there are, again, a number of people in the audience who I can't see because of the lights, but Tony Monday, Daniela Andrick, myself, Matt Jackson, was part of the Newcastle team who collaborated on this. So the trial essentially was measuring changes in the area under the curve of repeated measurements of the symptom score or the validated PROM from baseline out to 2 years after the procedure. And you had to be included, your patient had to have had 3 completed questionnaires or they weren't included in the final analysis. That was the primary outcome measure. The secondary outcomes were the need or time for re-intervention, the relative change in flow rate, perhaps not surprisingly, cost effectiveness, and the safety profile. The last 2 are in a separate paper. I'm not going to touch on the last 2 in this particular talk. Here are the centres, a lot of principal investigators that are in the audience. Just under 40 UK centres contributed to the study, from as many as 31 patients in Cambridge, which was an extraordinary effort. Congratulations to Cambridge, down to smaller numbers in a lot of the other centres. So we began recruitment in February 2013, and it completed in December 2015. We had powered the study to recruit 210 men, and initially there was slow recruitment. We were quite concerned that we weren't going to get up to target, but it gathered momentum, and in fact we ended up with 222 patients eligible and subsequently randomized into the trial. After the 2015 endpoint, we had 2 years of analysis and follow-up. So the trial closed in December 2017, and we worked on the analysis until the final data was available to us in May 2018. So baseline characteristics very similar in the 2 groups, just over 100 men in each arm. Age slightly on the perhaps higher side than you might expect, at about 48 or 49. The length of stricture very typically 2 centimetres. The flow rate 10 mils per second. And about 1/3 of patients had had a procedure more than 12 months before they were recruited, and about 2/3 were more recently within 12 months of recruitment. And the treatment they received, this is one of the limitations of the study we can discuss perhaps, is that slightly more than 20% or so crossed over. They were randomized to ureterotomy, and they actually didn't like that, so they were crossed over to urethroplasty. And I think you have to bear in mind, these are patients who have already had a failed procedure. They've had a failed ureterotomy, so there's going to be some inherent patient bias as to the effectiveness of the procedure. And I think it's a tribute to the research teams and the clinical nurse specialists involved that there wasn't more desire to cross over in the trial than actually happened. And a small number ultimately chose not to have any treatment at all, and there are a whole range of different reasons for that, but not huge numbers, and nothing that we would think would change the outcome data necessarily. The patient-reported questionnaire rates did decline a little. They tended to decline almost straight away, so the same sorts of people started to refuse to provide the posted out questionnaires. So we ended up with somewhere between 60 and 70% of all the data collected by the trials centres by the end of the 2 years. But the differences were relatively similar in both arms, so again, we don't think that necessarily changed the fundamental data and results that we have. So what did it show? Well, this is the main slide that I want to show you. So of the 220 men that were randomized, just under 160 were eligible for essentially for full analysis, that completed all the sufficient data. And you'll see it on the y-axis, the symptom score ranging from 0 to 24. So people began with a symptom score of around 13 out of 24, and immediately it drops down to 4 or 5 after the procedure. And both arms, it slowly rises up to the 2-year point, where the symptom score was about 7, and there was no significant difference in symptoms as measured by the validated PROM between the two arms at the end of 2 years. So symptomatically, both groups were exactly the same. Moderately improved, or moderate to significantly improved. The strength of stream, we have a stream score, was similar in both groups. It followed the symptom score very nicely. The quality of life score, the global quality of life score, again, very similar in the two groups following the symptom score. And the flow rates, this is what you're probably most interested in. The flow rates actually were the same, really, at 2 years. The urethroplasty group had a slightly better flow rate at the start due to some crossover, even though they were similar at the start. But you'll see that the ureterotomy group went from 10 to 19, and the urethroplasty 13 to just under 22. So the flow rates essentially were the same across the 2 years. Is there any hope for the reconstructive surgeons? Well, this slide does show some hope. The need for reintervention was lower in the urethroplasty group, and the time to reintervention was longer in the urethroplasty group. Now, 16% of urethroplasties were deemed to have failed, and 28% of ureterotomies in that time period. And failure was defined as restoration of symptoms back to baseline, or flow rates back to baseline, or someone has decided with the patient to re-intervene by cystoscopy or endoscopic dilatation, whatever it might be. So that was the definition of failure in this study. The re-intervention rate, 474 days for urethroplasty and just over 300 days for ureterotomy. That was statistically significant. So, in conclusion, we now do have some high-level evidence of the benefits of both ureterotomy and urethroplasty when counseling patients out to 2 years for these procedures. We can say that your symptoms will be much better, but we can't say there's any difference in symptoms between the two possible procedures that you're being offered. We can say that there's no difference between the outcomes symptomatically, but we can say that the likelihood is that you'll need something more done in the future if you have slightly more likely to have if you have a ureterotomy than if you had a urethroplasty. So, 2 years, is that long enough? Well, arguably not. And certainly, although the trial funding has finished and the trial itself is closed, we are intending to follow up the data at 5 and 10 years with HES, and we can obviously see what interventions have happened over those time periods. We want to look at ways of seeing how much different urethroplasty procedures are across the country. How long are people staying in hospital? How long are they having catheters? Can we, if you like, sell urethroplasty in the same way as we can sell ureterotomy, which at the moment I don't think we can. Patients don't like the idea of having prolonged catheterizations. That's certainly one thing that I experienced. And finally, what are the things that drive choice? How do people make their decisions? What are the factors that will influence their decision-making if there is equivalence in some ways between the two procedures? That's food for thought. That's something we could debate. But I'd like to finish with the same question that we asked at the beginning is, based on what you've just heard, would you still offer what you offered originally to a young man? So would you offer them a urethroplasty based on what you know and what you've just heard? Sorry. So that's, oh, here it is. So there, that's interesting. So obviously now I've sort of convinced you that you shouldn't offer urethroplasty quite so often as you did at the beginning. So we've got, it's almost 50-50 in the decision making. Okay. Thank you very much indeed.
Thank you very much for that, Nick. There's a theme in the questions that are coming through on the iPad, and that is, did intermittent self-dilation, was that used in the urethrotomy group, and did that contaminate the data? I think I know what your answer will be.
Okay. Very good question, whoever asked it. So about 1/3 of the men had all of the 220, about 1/3 of them had some experience of intermittent self-dilatation in the past. Now, some of them were actively self-dilating before they were recruited, and some people just said they'd had it done in the past. So 2/3 had never experienced self-dilatation, and afterwards, something like 20% of the urethrotomy group self-dilated afterwards for a period of time. And we have looked at this data. It's only obviously small numbers. It doesn't seem to have made a great deal of difference to the analysis, and they weren't doing it continuously throughout the 2 years of surveillance. So it was a pragmatic trial. We did allow that as an option, but I don't think it's made a huge difference to the outcome of the study.
That's great. Thanks very much. There's loads of questions, but unfortunately we've got to keep to time, so we're going to ask. We'll end it there. Thanks very much, Nick.
Thank you.
That's great. Next speaker is Ian Eardley, who probably needs no introduction. He's going to talk to us about the Baggers urethral surgery consensus. So the floor is yours.
Thank you very much. Good morning, everybody. Baggers, for those of you who aren't aware who it is, British Association of Genito-Urethral Reconstructive Surgeons. It was a group that got together, I think probably for the first time about 10 years ago, and they've met. It's a small craft group, about 45, 50 members of surgeons who undertake urethral reconstruction. We tend to meet about twice a year, once at the the UCL reconstructive meeting and once during this meeting. The guideline, the consensus, was something that was initially developed probably about 6 or 8 years ago. It was done in an iterative way. It wasn't done in any formal sit-down review of the evidence process like guidelines usually are made, but it was done in an iterative way. That means there was a first draft written. It was written by Tony Mundy. It was circulated to the members of the group who fed back things they disagreed with, things they would wish to see altered, which resulted in a second draft, which went out again, further comments back, and ended up with a third draft. And it really had two purposes. One was to provide guidance for non-urethral reconstructive surgeons about when to refer to a reconstructive surgeon. And remember, this was about 2012, 2013, so it was pre-open. It was before the results of the open trial were available, or even the trial had even begun. And it also sought to make recommendations about the choice of surgical technique for reconstructive surgeons. So it had two purposes. One, for the non-specialist as to when to refer, and secondly, about the sort of interventions that the specialist, the reconstructor, might wish to do. Now, given those timelines, a number of things have happened. The first one, and it was alluded to in Roland's initial introduction, was the publication of National Commissioning Guidance for Urethroplasty, Urethral Reconstruction in 2016. This publication came out NHS England at the same time as the publication about penile implants, and at the same time as a similar publication about sperm retrieval. For those of you who put penile implants in, you'll be aware that that commissioning guidance has led to a process that is likely to see reorganisation of penile implant surgery within England. Nothing's ever been done about this, but in theory it could be. And it is really quite relevant for those of you who undertake urethral reconstruction. For instance, in the guidance it makes statements such as this: NHS England will routinely commission urethroplasty for the treatment of benign urethral strictures in patients following assessment by an MDT, including urologist specialising in urethral surgery. Then it goes on to identify patients who might be specially commissioned. And if you're specially commissioned, that means you are centralised into a reconstructive centre. So the publication of this guidance implies that sooner or later, NHS England will seek to reorganise the way that urethral reconstruction takes place. The other publication that's been relevant was the publication of the AUA guidelines, which is available on the website. It is an evidence-based guideline from the great and the good from North America. And it seeks to make statements about the management of urethral strictures, and there are 32 guideline statements. The evidence is categorised according to the strength of the evidence, and then evidence-based statements make recommendations largely on the basis of that, the evidence. Now, what is interesting for those of you who've looked at it is that actually, for most of those statements, there is not much of a recommendation, and there's not very much evidence, if the truth be told. And most of those statements end up requiring what's called a clinical principle as a means of directing management, or expert opinion as a means of directing management. And it really behoves all of us to note that there's a lack of evidence in this field. So with the context of those two documents, the UCL group have revised their document, and it's been was rewritten last year again, prior to the results of the open study being available. And they make 32 statements which work through 4 areas. Firstly, about the use of terminology, the definition of urethral stricture, the need to include urethral stricture as a differential diagnosis in male lower urinary tract symptoms, a statement about diagnostic workup, nothing that anybody in this room would find surprising. You need to take a history, you need to use a patient-reported outcome measure, you need to do a flow rate and a bladder scan and a residual and a urine culture. All sorts of very, very common sense statements for which actually there's not an awful lot of evidence. Then it works its way through the treatment options through conservative management, urethrotomy and intermittent self-dilatation, and the various sorts of reconstructive surgery, both for bulbar strictures, traumatic bulbar strictures, longer bulbar strictures that require augmentation, the use of non-transecting techniques, penile urethroplasty, and strictures of the meatal and navicular fossa. Now, there are 32 statements there. I don't propose to go through them because I don't actually think the document as it stands is the finished article. And you're going to save some time on me because this is my last slide, because actually I think we need to have a serious think about whether we need to produce a document of this sort for British urethral reconstructive surgery. The document as it stands is slightly out of date. It doesn't have the benefit of the data from the open study within it. But in the context of an environment whereby specialised commissioning might well be introduced, I'm always reminded of a phrase that was attributed to Harold Wilson. For those of you old enough to remember, he was a Prime Minister of this country. And he said that he who writes the first draft of a document will have the greatest influence over the ultimate outcome of what happens. And it seems to me that if NHS England is likely or may introduce specialised commissioning for urethral reconstructive surgery, the publication of a guideline document that is specific to the NHS in which we all work about the way in which urethral strictures could or should be managed would be a useful thing for us to do. And I think there are ways that we could update the document and seek publication. Now, to a degree, what I'm saying now is a personal opinion. And hopefully I've given you all some time to give me some thoughts and your thoughts on how we should take this document forward. Thank you very much.
Thanks very much, Ian. Again, please feel free to put your hands up if you've got a question or use the BAUS app. Slightly put you on the spot, Ian. Having just heard what Nick has said, do you think that's going to be a game changer in terms of guidance on urethroplasty?
You're asking me to review the open study. Well, I'm a glass half full man. I don't think the follow-up was long enough. I worry that the PROM was not necessarily the right outcome measure to be looking at. And I think if we wait longer, we'll see higher reintervention rates. But I don't have any evidence to substantiate my personal opinions.
Okay. Any other questions at all?
I mean, we have got our meeting from 1 till 2 in here, so we can always go through things in more detail with a smaller group then.
Well, could I ask the audience, it's difficult to see up here in the light, show of hands, who thinks there would be value in a British-specific consensus document on the management of urethral strictures? Show of hands saying yes. And no? Okay, so that's the majority of the room. Thank you very much.
Thank you.
Okay, I'd like to ask Asif Munir to come up now. Asif, been a consultant at UCH for about 12 years now, I think, gold medal winner in the exam, and, you know, an authority on andrology. So please tell us about the BAUS penile prosthesis audit.
Okay, thank you very much, Paul, and welcome to everyone to the section meeting for this year's conference. I hope you enjoy Glasgow. It'll be the last time we'll be here for a while, so make the most of it. So I was asked to give an update on the penile prosthesis audit, and what I'm going to do is give you an overview of where we've been in the past and what we've done with the initial analysis of the data. So if you look at the last time that we actually published anything related to an audit on penile prosthesis in the UK, it was back in 2006. And you can see here there's just over 400 procedures, and this was based on company data. So AMS and Mentor at the time provided their data for analysis. It was for a 2-year period up to about 2004, so 2 years from 2002 2004, and it was published in 2006. We can see over here is that just over 400 procedures were performed, and the number of surgeons performing 1 or 2 implants per year was quite substantial. There was only 4 surgeons in the country doing more than 20 annually, and the rest were just spread out in the middle. So you can see that out of the 76 or so surgeons that put in their data, 49% had only done 1 over a 2-year period. So I don't think that's sustainable in this day and age. I think surgeon volume is important, regardless of which procedure that you do, particularly if you're doing any complex or specialised surgery. I was going to just compare with which other registries are being done internationally. So this is one from the USA. The criticism here is that it only covers AMS devices. So this is the proper study. You can see that the most popular implant placed here was the LGX, which is an AMS device which gives you elongation as well as girth, and by far that was most popular. So they put in just over 1,000 patients in 14 centres, and just give an overview of what they found in terms of etiology. You can see the most important groups here were diabetics, those with vascular disease, and those with previous prostatectomy. So that's your kind of your patient groups which are undergoing penile prosthesis, and it doesn't differ too much amongst continents and different countries. But what you do find is there's a variation depending on how proactive surgeons are with regards to radical prostatectomy as to whether diabetics or post-radical prostatectomy make the largest group. This is another one. This is a European study. This is the INSIST ED study, which is an Italian registry. In this one, you've got 37 surgeons and just over 350 cases. The majority, again, were inflatable penile prostheses. What we found in this study was that those surgeons who weren't really implanting very many were more likely to do malleable penile prostheses rather than inflatable. There was also just generally a higher proportion of malleable prostheses compared to the American study. So this is a European-based registry. Now, the need for a penile prosthesis audit here in the UK has really been based on the change, like Ian said, the change in how we're going to be delivering this service. The problem that we have is that there are just 2 companies that make the penile prosthesis, but they're not going to share data. They do give us a ballpark figure of how many implants have been put in per year, but apart from that, the patient information form that you fill in when you do a penile prosthesis isn't going to be open to us at BAUS or to any other individual, despite going through all the formal process to request it. So we've had to set up our own audit, which then obviously acts as a similar registry. I think the other issue is with all the problems with the hips, the breast implants, and now the mesh, we are implanting foreign material into people, that there has to be some kind of governance process, and I think the BAUS penile prosthesis audit will also help with that. And finally, if you've all had a look at this, which is the penile prosthesis commissioning pathway, you can see here that when you read the actual guidelines for management, so this is only relevant for NHS England, so Scotland, Ireland, Wales, they'll have their own policies, but with this one in England, where the majority of the prostheses are performed in the UK, it does say there is a mandatory requirement to enter your data onto a national registry. So that's another reason why we've had to continue with the audit. Roland gave a update last year, and these were the figures. You can see that when we updated it 2018, obviously we only had half the year entered. There were 739 cases which had been entered, and the number of sites which were implanting the implants. So this is over an 8-year period, 27 sites. But if you look at the number of sites annualized from 2015, you can see that when the audit was launched in 2016, the number of centres has been gradually reducing year by year. So that's where we were last year, and you can see just over here, by the middle of last year, the median number of procedures was 13. So that's across the whole period. So people were putting in retrospective data as well from 2010. But what we've decided now that we're doing the analysis is that we're going to just use a prospective data. So this is data that's been collected from 2016. So we've got a 3-year period that we've just analysed, and we're going through, sieving through the data to make it more meaningful. And altogether, we've got 1,071 procedures which have been registered, which isn't, so this is across the UK. It's not that different to what the HES data has shown. There is a bit of variation, and also just informal estimates from the companies. There is a slight variation, but not substantial variation. So I think people have done very well in terms of putting on their procedures onto the audit. The number of consultants and the number of centres, you can see by 2018 there's 13 centres that put in the data and 20 consultants performing the procedure. So it's remained fairly consistent over the audit period. So that's the number that we're going to be working with. And when you start doing the sub-analysis, as with all the other registries internationally, the majority of them have been inflatable penile prosthesis. We're talking about either 3-piece, the majority, or 2-piece devices. Only 14% have put in a malleable penile prosthesis. If you look at the divisions in terms of which company has been most popular, so Coloplast by far has got over 50% of the market when it comes to inflatable penile prosthesis, with AMS contributing the smaller figure. But when you look at the numbers per centre, so this is again over the 3-year period that we're going to be analysing, you can see that there's one centre that's done over 600. The rest have been sort of distributed around the country, and you can see that the median now is 8.5 per centre. So that's where the analysis is so far. We've looked at the etiology, and again, similarly to the American and Italian studies, the big groups are diabetics, post-prostatectomy, and Peyronie's makes quite a large cohort as well. So what I've done here is I've just picked out the top 10 reasons for undergoing the penile prosthesis. The median age of the patients, 54, which is a bit younger than we expected. And I've just put down the main complications that have been listed. So you can see the intraoperative complications, such as perforations, this proximal distal perforation is going to be less than 1%. Prosthesis infection, 0.5%. Commonest complications have been reported, scrotal hematoma, about 1%. Penile pain, postoperative pain, 1%. We also looked at antibiotic use. So the most commonest antibiotics given is coamoxiclav, and followed by ciproxin. Some people also give gentamicin. So we've looked at the patient preparation in theatre. Most people will do a scrub in theatre. So we're going to be analysing all of that data for perioperative use as well. So where are we going to go in the future? Well, the slight problem that we have at the moment, which is hindering the data being meaningful, is that very few people are putting in the outcome data. So if you go into the audit, there is outcome data that should have been collected. What I would request is all of you who have put in your data, please go back and try and put in the outcome data. We've not got a huge amount of outcome data at the moment. And I think so this will be the largest registry, and I think it'll be useful for you to go back and look at least patient satisfaction and are they having sex with the implant. So there's some data missing. Also, there was something we sent around about consenting patients. So if you're doing it prospectively, do make sure that you've consented them to allow their data to be uploaded onto the audit. And please, can you fill in the fields a bit more accurately? So there's still a large proportion that haven't mentioned which implant it is. They haven't mentioned anything about perioperative antibiotics. All of that data is going to be important. Thank you very much.
Thank you very much, Asif. Minimum numbers is always a bit of a difficult topic. Do you have a personal view on what the minimum number per surgeon, not per centre, but what minimum number of implants should a surgeon be doing a year to maintain his skills?
I mean, yeah, it is a difficult question because there isn't really a huge amount of evidence. I mean, there are some studies which have shown higher volume implant centres have better outcomes, for instance, and that's just with AMS devices. I mean, it's with anything, what do you need to do to maintain a skill set? Now, do you need to just be doing complex penile surgery, so a little bit of Peyronie's, a little bit of, reconstruction, and the implant to maintain your skills? Or do you need to specifically do a penile prosthesis to maintain your skills? And I think, realistically, I mean, doing one a month will just keep all your theatre staff and, all your support staff, prevent them from being de-skilled. So, I mean, around about 12, 15 a year possibly might be a reasonable number. I mean, you've got to balance it with, what the needs of that same population are. I mean, I definitely feel that, you can't be doing ones and twos now. I mean, I think those days have gone, and I think most people will agree that with any procedure, you shouldn't be doing one or two a year, particularly, if you're doing two a year, you get one infection, and suddenly your infection rate goes up to 50%. So, I don't think it's worthwhile doing that. You want to kind of dilute your complications as well. So you don't want to be doing, 5 and you've got complications in 2. So all of that is going to be looked at in terms of, where the commissioning is going to happen in England anyway, but not necessarily around the UK. So I think the number is fairly arbitrary at the moment.
Okay, some questions in the audience. Mark Lucky would like to ask a question.
Hi, Asif. I think we need to be very cautious when we're looking at this data because from one of your slides it shows the decrease in trends, both in numbers and centres. I think that's probably twofold. One, because that represents a change in funding, namely the dropping of individual funding requests, which had a knock-on effect on the smaller centres throughout the UK, meaning their numbers decreased rapidly. Two, I think the other main issue is everyone was in a bit of a panic when this consensus statement was going to come out, so everyone started putting in their data. That's more or less not died a death, but nothing's happened from that. So I think people have taken their foot off the gas putting in data. So I think a lot of centres just aren't putting in data. So while that gives an idea of what's going on in England, I don't think it's truly representative of the actual geographic spread of these procedures.
Yeah, no, I agree. I mean, there was a change in practice because some centres weren't being commissioned, I agree. That's why there's no centre names on there. So this is all sort of anonymised. the whole idea here is to give you an idea of what's happening in terms of what types of implants, what perioperative complications we're having. I mean, that's going to be really the fundamental thing here with regards to the audit, because we can't name centres and we can't name surgeons, so it's just really a snapshot of what we're doing here in the country.
Okay, Mike Fraser would like to ask a question.
If I have a couple of points, really. I would have thought that the naming of centres was particularly important. My concern is that with your figures, which are very interesting to see, the number of centres has gone down, the average numbers have gone up, and the complication rates seem really low. And what my cynical brain says to me is there are still lots of ones and twosers out there who are not reporting their data and their complications. So I think I would bear in mind the need for openness, and I wouldn't think those of us who do a significant number of implants would have any objection to being named and, if need be, shamed. And my second point, as you've come to Glasgow, when NHS England screws you over, we'd be quite happy to take some more of your cases. Thank you very much.
Yeah. Yeah, the only slight problem is I don't think patients want to travel up here, because that's a problem we've had with our delegates. Yeah, no, so, I mean, yeah, I agree. This is why we've looked at HES data and we've looked at company data as well. And you'll be surprised there's not a huge amount of difference. Although, yes, there will be some centres which are performing the procedure and not recording and not filling in the audit. But that's going to happen with any audit that you do. So you're going to find that, even for the nephrectomy audit, which is important for COPS, etc., people aren't going to put in all their data. So we're never going to have a robust audit or registry. But, it is, over 1,000 cases over a 3-year period, almost, reaching the numbers that the companies say are being done. So it's the best thing that we have. With regards to, this isn't an exercise for naming and shaming. This is an exercise just to give an idea of, for those who are doing 2 a year, to show, where, because they know who they are, okay? They'll know where they are compared to everyone else. The other thing is, we want to give an honest opinion with regards to complications. I mean, if you aren't putting in your post-operative data, your complication rates, then, this kind of thing is meaningless. And at the moment, we've probably had outcome data from about 250, so it's only about 25% of what's been put in. So we need to improve that to make this a fairly robust outcome. So I do plead with you, those of you who are putting in data, to go back and try and at least see what's happened with the follow-up with the patients. Let us know if they've had revisions, infection, what's the reason for revision or explant. All of that data is important, because this will probably be the most powerful registry published once we have all that data.
With that in mind, can I just ask you to put your hand up if you're putting data into the penile prosthesis audit? And can you keep your hand up if you're getting reminders about follow-ups? I think that's one of the issues. I don't think people are getting the reminders.
Yeah. I mean, we used to do it in the newsletter if anyone read it. I think what we'll do now that we've looked at the data and we've looked at where we're lacking, we can just send out reminders. So although the audit was going to follow up the patients at 3, 6, 12 months, I mean, as long as we get, say, something at 12 months, that may be enough.
Yeah. Okay, thank you very much. I'd like to invite VB Modgill up to the stage, my old registrar, who's gone to do great things since he left me. I think a year in Australia, a fellowship down at UCH, and now recently a consultant appointment at Manchester Royal Infirmary.
Thanks very much indeed, Paul. Ladies and gentlemen, good morning. I am happy to be in Glasgow, by the way. It's a pleasure to be here. And just before I took up post in Costadale, Manchester, as we call it locally, I was asked to go away and find 4 papers and come and talk to you about them. I think they're interesting, but of course you might not agree. So without further ado, I'm going to be talking to you over the next sort of 15 minutes about fertility, testosterone, a little bit of surgical technique, because we're surgeons and that's what we like to do. And I'm going to finish with a bit of wisdom, not from me, of course, because what do I know? So the first paper, in my opinion, is truly spectacular, and I don't say that lightly. I don't think this is just an important paper andrologically. I actually think this is just a fantastic bit of science. and it was published by Kyle Orwig's group from the University of Pittsburgh, and the paper was published in March in Science. And what this group did was look at autologous grafting of cryopreserved testicular tissues from rhesus macaque monkeys in the back and in the scrotum, to then eventually go on and produce sperm. Now, that's been done before, but the actual production of offspring is something that hasn't. So why is this important? Well, we know that survival rates from childhood cancer are improving. 30% of children will, unfortunately, go on and develop infertility, and that's because of the chemotherapy and radiation therapy they might receive. The only options available to us at the moment are cryopreservation, and that's from testicular tissue, which does have spermatogonial stem cells. And as we know that in prepubertal boys, this is far more of an issue. So what did they do? They took 5 rhesus monkeys. So there's a chap there. If any of you have traveled to Asia, they're around. And what they did is they performed what they describe as hemi-castration and then completion of castration. So they removed a testicle, 5 to 7 months later, came back, removed the other testicle, and in both instances took tissue for cryopreservation and fresh grafting. This tissue was then placed at 6 sites in the back, just under a skin fold, and also under the scrotum. And as you can see, there's tissue there. They sew that in and then put the skin flap back over. Now, something quite remarkable happened with these macaque monkeys. 8 to 12 months later, they actually had normal testosterone levels. So that showed an intact hypothalamic pituitary axis in these patients, despite having been castrated with the tissue that was placed in the back and in the scrotum. The other thing that happened was when they went to remove this tissue, 5 times increase in weight of tissue. So this tissue was actually growing despite being put in the back and the scrotum. There was no difference at all in the tissue that was cryopreserved versus the freshly grafted tissue. However, there was a difference between the tissue that was placed in the back and the scrotum. So tissue in the scrotum did better. It weighed more. They fertilized 138 eggs. 39 of these went on to the 2-cell stage, and 16 developed into blastocyst stage embryos. And there you have it. So 11 blastocyst stage embryos transferred into 6 females. Lo and behold, they performed an ultrasound scan on one of the females, which showed a viable pregnancy. And in April last year, baby Grady was born. So, you know, a truly remarkable bit of science and a remarkable achievement. The baby, to the best of our knowledge, was perfectly normal, well within average limits for weight and height and cognitive function as well. So where does that leave us? As I keep saying, this is pretty amazing stuff, not just andrologically, but in science, full stop. However, there are some important points for us to consider here in terms of our practice. The macaques were castrated, and of course that doesn't replicate the scenarios that we deal with in real life. The second thing to say is that this tissue has been collected before cancer treatment. So that does have very serious implications about where we go and graft this tissue, because the last thing we want to be doing is transferring cancerous cells into patients. The other thing to say about this is that there's certainly a scope for this technique to potentially be used in solid tumors such as sarcomas and neuroblastomas, which we know don't metastasize to the testes. Now, you don't just want to listen to me, so what I did is I spoke to a friend and colleague, Martin Alberson, who some of you will know, to give us his summary.
Hello, British urologists. I hope you're having a good morning and a good andrology session at the BAUS meeting this year. Thank you, Phoebe, for inviting me to provide a brief comment on Kyle Orwig's paper in Science 2019. Very briefly, they grafted testicular tissue from pubertal monkeys, which was cryopreserved before, and they did that in the back and then under the skin of the scrotum. And what they observed was that these grafts grew, they produced testosterone, and they produced sperm that was sufficient of quality to have a live birth of a female monkey. So, 2 things we have to keep in mind here is 2 drawbacks. First of all, the study was done in pubertal monkeys, which were castrated, and in non-castrated animals, this technique has not been validated yet. So this is something that needs to be done before translating to clinical practice. The other thing is, we obviously, if we do this in young cancer patients, we don't know whether the testicular tissue that we engraft contains cancer or does not. So for now, we just can use this for sarcomas or other solid tumors that we know that don't metastasize to the testes. But we have to have some patience before applying this in lymphomas, leukemias, and testicular cancer. So thank you very much, and have a nice BAUS meeting.
So there you are. Paper number 2, lessons from the testosterone trial. This was Peter Snyder's group. And as some of you will know, they essentially looked at 7 overlapping trials. Why is this important? Well, we know testosterone is tremendously controversial still, despite there being reasonable evidence for its use. We know that testosterone levels also drop as men get older. What did they do? They looked at 7 trials focusing predominantly on sexual and physical function, as well as what they describe as vitality. There was 4 other trials, although they weren't the dominant forces in this paper, but they consisted of cognitive function, a trial in anemic patients, looking at bone density and cardiovascular risk. So testosterone, the aim was to show whether testosterone makes any difference when it's given to older men. The testosterone gel preparation was used versus a placebo gel. It went on for a year, and it was prospective, randomized, placebo-controlled and blinded. So, inclusion criteria: men over 65 with the testosterone value that you can see in front of you, and these men did have comorbidities. In saying that, the exclusion criteria was fairly stringent. If there was a history of prostate cancer, or they felt that you were at risk of developing A, prostate cancer, or B, high-risk prostate cancer, you were excluded from the study. You were also excluded if you had moderate low urinary tract symptoms, any history of cancer, cardiac, renal, or hepatic disease. So reading that, it made me think that doesn't leave you with a lot. So they performed telephone screening, essentially, of over 50,000 patients and managed to get just under half of those to the first screening visit. In doing so, what they found was that 21% of these patients had a low testosterone, but importantly, 10% of those had low T and prostate cancer risk, because if you had a high prostate cancer risk, you weren't allowed to be in this analysis. The second time round these patients came round, they found that only a percentage of them had a low testosterone again. So that gives us the importance of performing more than one testosterone, making sure it's fasted, making sure it's early in the morning, because otherwise you will pick up anomalous results. So they got roughly 800 patients, 790 in the trial, 2 were randomized incorrectly, so they were taken out. And they looked at medium serum testosterone concentrations from being unequivocally low to within normal ranges for a young man. So let's get to the crux of it. Sexual function. Basically, they used a psychosexual daily questionnaire looking at any type of sexual activity, starting from flirtation right up to penetrative intercourse. And what they noticed was that in the testosterone group, there was an increase in sexual activity. Activity 4 times a week. And they describe this as modest. I'll leave you to make your own judgment of that. Physical function. So primary outcome was distance walked in 6 minutes, and significance here was if an individual could walk 50 meters more than they did at baseline, they considered that significant. In the subgroup of this group, so a small percentage of them that were in the physical function trial, they didn't find any significance. However, looking at the 788 men altogether, they did, to suggest that physical function did substantially improve. Vitality. So this essentially is looking at fatigue. So from gross fatigue to very energetic. And they used the Facet Fatigue Scale, and essentially what they did show is that, unfortunately, testosterone didn't make a huge difference in this. It did, however, pick up mood and depressive symptoms. What about cognitive function? Slightly busier slide, my apologies. However, the crux of it is testosterone makes no difference to cognitive function. In the anemia trial, they picked up 62 patients who had unexplained anemia, and looking at these patients, again, they noticed an improvement, which isn't unexpected because we know about the effects of testosterone on erythrocytosis, and they showed that the concentrations did go up by over by 1 or over gram per deciliter. What about the bone trial now? I think this is probably one of the most significant findings of this paper. What they found was in the 211 men in the bone trial, testosterone treatment for a year did increase volumetric bone density, particularly of the trabecular bone in the spine, by up to 6.8%. That is the sort of difference that you see if you give osteoporotic women bisphosphonates. So there's an argument to say that this is very significant indeed. Cardiovascular risk, there simply aren't the numbers in this trial to make an accurate judgment about cardiovascular risk. However, what they did was use a surrogate marker, which was an increase in non-calcified coronary artery plaque volume. And unfortunately, they did see in the 138 men that they looked at that this did increase. So testosterone isn't without cardiovascular risk. So again, a quick expert summary of this. Jeff isn't here this year, but many of you will know him, and I just got him to briefly give us his comments.
In lessons learned from the T trials, Peter Schneider summarizes the finding of the largest study yet conducted into men with hypergonadism. The study found that men with low testosterone at baseline had significant improvements in all aspects of sexual function, not just erection, and were indulging in some form of sexual activity at least 4 times a week, described by the authors as modest. There were also significant improvements in all aspects of vitality, particularly walking distance, which improved particularly in the men who had preserved function at baseline. There were improvements in anemia levels, as about 15% had baseline anemia, and this was corrected in well over 60%. There were also improvements in mood and depression scores, but most importantly, there was a 6.8% improvement in bone mineral density, which was thought to translate into benefits equivalent to those who are taking bisphosphonates. Thank you very much for reviewing this paper at BAUS. Thank you.
Okay, so paper number 3, and this is the surgical technique paper because I didn't think I could do this session without talking about surgery because that's what we all do. So this is the PICS technique, and it's been popularized by Georgios Hatzichristodoulou, who works in Germany. This was produced in JSM, a very small number of patients with both erectile dysfunction and Peyronie's disease. We know that these patients can be quite difficult to manage. As you'd expect, they'd all failed medical therapy and had baseline assessment. Now, this group of patients was a group of patients who had penile prosthesis insertion, inflatable, and following the insertion, they found that they still had a residual curvature of 40 degrees or more. So the question that's being answered here is, what do you do with that? And we know this has been argued about for many years, from modeling to adjunctive procedures. There are several options available to us. So this is what they did. So as you can see there, this is a penoscrotal implant. The implant's been put in. The pump still needs to be popped into the scrotum, an open insertion for the reservoir. But you can see there that the patient does have a good going residual curvature and perhaps a little bit of wasting and indentation as well. So what do they do? What does Georgios suggest we all do? They perform a degloving incision once the implant's in. So the bit where the implant goes in is exactly as you would do normally. You close both your incisions, but then you go ahead and make a degloving incision. Upon doing that, you then incise the plaque, and what that does is it essentially springs the penis back into a straight position, but you're left with a defect, as you might expect. The third thing they do is they put Tacoseal on it, and those of you, I personally haven't used Tacoseal yet, but I know some people in the room have. It sounds very good. The cynic in me, it sounds too good to be true. This is essentially a patch that you can put on, which you don't have to sew in, and of course that negates the risk of injuring the implant if you had to do this in any other way. And there you have it. So bucks and neurovascular bundles have been put back down, sewed back over, and certainly looking at that picture, I think it's hard to argue that it isn't straight. So small number of patients, nice technique, but small. No long-term outcome as such. They report an 80% success rate and tell us that 3 of their patients had a residual curvature of 10 to 20 degrees, and I think very reasonably that was left alone. And the patients seem quite happy. They report no immediate or late complications whatsoever. So here's Georgios, who I caught up with last week, and he's going to give us a quick update.
Georgios, thanks very much for agreeing to talk to us about your paper.
Paul's given me the signal, and having been his registrar, I know that looked very well. So I'm going to move on to the next paper. So this is a very quick one indeed, and this is just a bit of light relief before I finish. This is an excellent paper, an entertaining read by Steve Wilson, who needs no introduction. So he talks about 5 lessons, 5 things he wished he knew earlier in his career. Never implant a stranger, and if you do, then basically see them as much as you can, as often as you can post-operatively. If they have a complication, see them even more often until the patient gets sick of seeing you, and be nice to them. Number 2, treating erectile dysfunction and Peyronie's, as we've just discussed. Now, Steve was the one who popularized the modeling technique, but interestingly, in this paper, he suggests that perhaps we shouldn't be doing that because of the risk of urethral injury and the weakness at the fossa navicularis. The modeling that I did, most of which I did in my fellowship, I didn't see that, but he's going against his own early advice there. Number 3, ectopic reservoir placement. This is still the sphincter clenching moment for me. Maybe that'll ease over time, maybe it won't. But Steve Wilson suggests that we should be doing these ectopically and not in the space of retzius, and the complications rates will be lower. Number 4, never rush to revise an IPP. Wait, and wait some more unless there are real indications to do so. Glands ischemia, infection, pus and blood being the obvious ones. Number 5, Steve suggests don't do a sphincter and an implant at the same time. Deal with the most bothersome symptom first. That tends to be incontinence. Let's face it, if you can't get an erection, it's not necessarily something that bothers patients more than being incontinent. I did have an expert summary, but luckily for me, he's coming up next to do a lecture, so he's going to hopefully give us 5 more tips as well. I'll leave you with that. That's at the end of Steve Wilson's paper, and you can all have a read. Thanks.
Well, thank you very much indeed, VB. That was excellent. You know, I think the 2 younger consultants have really raised the bar and the quality of, you know, the appearance of presentations. I don't mean that to be derogatory to anyone, but that was, you know, another fantastic talk.
Thank you.
So
I'd like to invite Roland up now to introduce our next speaker. Thanks very much for this session.